what are rare diseases, and why does it happen to a certain person?
A lot of difficult situation where you have to find out the diagnosis, you have to treat these patients because you don't have a lot of data about these patients. That's why these are considered as rare diseases for us. So how do you find out a treatment for such a disease when you don't know how many patients are there across the globe, when you're not able to study on them? There are few diseases for which rare diseases we have found out that these are the reason, these are the genetic changes, but most of them still unknown.
This episode is dedicated to the rare diseases. What are rare diseases? How it happens? Who these rare diseases happen to? What are the diagnoses of these rare diseases and what not? Of lately, there was this 37-year-old Mumbai man who was diagnosed with intestinal tuberculosis. This is one of a rare disease. He was treated by Dr. Samrat Shah of Apollo Spectra Pune. Dr. Samrat Shah is here with us in this episode to discuss more about not just this case study, but also about many other cases and to discuss more about the rare diseases. Doctor told us that, how even a small symptom can lead to maybe a rare disease. So one should never ignore them. So do join us in this episode to know more about rare diseases with Dr. Samrat Shah. Welcome on the show, Dr. Samrat.
Hi.
Hi.
Yeah.
Good to
How are
have
you?
you. I'm doing good. How are you?
I'm good, very well.
Okay. So we got to know about this, like, your achievement where you treated a man of 37-year-old who had intestinal tuberculosis. So, and this is known as a rare disease. I
Right.
really want to know from you what are rare diseases and why does it happen to a certain person?
All right. See, now when we talk about rare diseases, these are the diseases where the incidences are low. Like if we talk in medical terms, diabetes like is considered as a common disease because today uh, every fourth Indian is diabetic. So that's the whole reason why we call it as a common disease. So rare diseases are something where the incidence of disease is so rare that you cannot do a case control study, you cannot do a randomized control trials on thousands of people, and it is not practically possible to conduct large number of trials and find out the way of treating them, find out the way of diagnosing them. So that's why they are called as rare diseases, because we cannot easily conduct a huge study on these kind of patients because we don't have that many number of patients, and then it becomes a lot of difficult situation where you have to find out the diagnosis, you have to treat these patients because you don't have a lot of data about these patients. That's why these are considered as rare diseases for us.
And why does it happen to a certain person? Like, say I had my father, who had this rare disease known as skull-based osteomyelitis. So I really don't understand why does it happen to a certain person.
Yeah.
What
Now,
is, like, the basically history behind this?
no, see, as such, for these rare diseases, no, as we discussed, the bigger trouble here is we don't conduct a lot of studies on these kind of patients. Now, you see, if I talk about intestinal tuberculosis, what we are talking about, if I talk about autoimmune pancreatitis, so these are the kind of diseases. Like I have seen a patient with autoimmune pancreatitis. The total number of cases reported across the globe are 92. So when you report only 92 patients across the globe, then how do you study on these patients? Then how do you find out what is the reason for these diseases? So then it becomes difficult to find out why this is happening. It becomes difficult to study on these patients because in any kind of disease like COVID vaccine, it was very easy to find out the vaccine because it was a huge bulk of disease load. Then in such kind of patients, no, it becomes easy to study. It becomes very easy to conduct trials and find out what is happening, how they are responding to drugs. Like we had remdesivir, we could test easily around 30,000 patients in a month. So when you are able to
Right.
conduct such large number of studies, then it becomes very easy to find out what is the response, what is the reason, what are the side effects. But when a disease is rare like this, then it becomes very difficult to conduct trials, and then it becomes very difficult to find out the reason why they are happening. So as of now, what is being told is the primary etiology for them is there is some genetic background which is definitely there. Along with that, some kind of environmental change or change in their environmental aspects, they add up together with genetic makeup, and that's how they develop those diseases. Now, what genetic reasons are there? Those things are very difficult to find out. Environmental factor, there is a long list being given, which are being told that they add up with genetic factors, and then they develop rare diseases. Like we saw a patient who was 18-year-old, and his blood pressure was 280, 260, in that range. And
Okay.
his father was having young hypertension. His father was diagnosed hypertension at the age of 26. His younger brother is diagnosed with hypertension when he's 16-year-old. So now this we could be able to find out that later on this is something called as Liddle syndrome. So now these diseases, Liddle syndrome is a disease where we have seen almost around 1 in 1000 or 100,000 patients, which means 1 in 1 lakh patients we can find such kind of patients. So these diseases have been studied. So इनका हम what we do is we send a genetic analysis testing for them. We know that this is the gene sequence that is affected in these patients, this is the genetic mutation that is happening in these patients, and if this genetic mutation comes positive, we label them with that disease. So labeling that each genetic disease for each of the diseases available which are rare is still not possible. There are few diseases for which rare diseases we have found out that these are the reason, these are the genetic changes, but most of them still unknown.
ओके सो अभी जो आपका केस है जिस पे आपने एक कहेंगे अचीवमेंट एक तरीके से आपने हासिल किया है बिकॉज दैट मैन वाज सफरिंग फ्रॉम इंटेस्टाइनल ट्यूबरकुलोसिस एंड दैट इज ऑफ कोर्स नोन एज अ रेयर डिजीज सो किसी भी रेयर डिजीज को क्योंकि मैं जानना चाहूंगा दैट यू नो हाउ because it is not easy to even diagnose a rare
Correct.
disease like you know because the symptoms are very common generally
Correct.
so um, कितना परसेंट ऐसे पेशेंट्स हैं जिनका लिटरली ट्रीटमेंट भी हो पाता है or those the ones who are able to really like you know in simple terms I shall call it that you know the ones who are able to make it.
करेक्ट. सी नाउ इसमें क्या है, अभी जैसे ट्यूबरकुलोसिस का ट्रीटमेंट सेम है, because we know that it is the mycobacterium tuberculosis bacilli that is causing this tuberculosis. We know how to kill this bacteria no matter wherever it grows in the body. Now we treated one young female 26-year-old from Yemen. She had come from Yemen. She came to us with a history of weight loss of around 14 kgs, and this article
Okay.
also we published a few months back. This was last year October, and the only complaint she had was fever. No other
Okay.
complaints. We looked for every part of her body, we did not find anything. We did genetic testing, everything we did, but did not come out anything. But then what we did was we screened her eyes, because one rare possibility is ocular tuberculosis. That is also very rare entity where the tuberculosis is there in the eyes. जो आई में स्क्लेरा होता है उसके पीछे कोरॉइड प्लेक्सिस रहता है, कोरॉइड प्लेक्सिस का एक टीबी होता है, which is very rare disorder. Incidence
Okay.
of intestinal TB, what we reported right now, is 1 in 1 lakh. But the incidence of ocular TB is 1 in 10 lakh. So that rare disease it is. So when we did those testing and then आंखों में हमें ये दिखा कि उसको कोरॉइड प्लेक्सिस में changes थे. So then we could be able to diagnose that this is a tuberculosis in choroid plexus or ocular tuberculosis. So then we know what bacilli it is causing. So when we know the disease, when we know the etiology of that disease, what is the agent that is causing that disease, then we can treat them. But there are so many other diseases where we don't know the etiology. So when we don't know the cause of it, it becomes very difficult to treat such kind of diseases. Like I was
Right.
talking to you about autoimmune pancreatitis. Now autoimmune pancreatitis, there are 90 cases reported across the globe. So how do you find out a treatment for such a disease when you don't know how many patients are there across the globe, when you're not able to study on them? Like whatever patient I studied was the first case reported in India. So when such kind of patients are there, they are not entered into trials, because I have only one patient in India. Where do I study? And how do I
Mm-hmm.
study on one patient? So such diseases, most of them, they cannot be treated. So then we just diagnose them and then leave it without doing anything. But if we know the etiology, like tuberculosis, be it ocular tuberculosis, be it intestinal tuberculosis, we know that the causative agent is this, we know how to kill these bacilli. In such patients it becomes easy to treat. But if I tell you on an average, it is 70 to 80% of these patients who cannot be treated.
Okay, and they do not make it even for that matter.
Yes, then they eventually succumb with complications. That's all.
Okay. One thing which I again want to know is that in case, like you know, you have any symptom, like you know, maybe some pain at some in some part of your body, or maybe like you know, mild fever, like you know, somebody suffers from a mild fever for like you know years and years, and they
Right.
report it, but they say that okay, it doesn't matter. I mean, ठीक है, हल्का हल्का बुखार रहता है, but ऐसा कुछ बॉदर वाली करने की बात नहीं है. They go to
Correct.
the doctor, doctor is also unable to diagnose the same, and they say कि ठीक है, just leave it. हो जाता है कभी कभी, कुछ लोगों के साथ में ऐसा रहता है. I want to understand that किसी भी तरीके का, even the smallest of the symptom, if that appears in your body, आपको क्या उसको, वो किसी ना किसी डिजीज से जरूर, मतलब 100% है कि वो किसी ना किसी डिजीज से, कोई अंडरलाइन डिजीज से मे बी एसोसिएटेड होगा, या ऐसा जैसे मैंने अभी बोला कि डॉक्टर्स भी बोलते हैं कि नहीं, लीव इट, लाइक उससे होता है कुछ
Hmm.
पेशेंट्स के अंदर, कुछ पेशेंट्स का जैसे ब्लड प्रेशर हाई रेंज में रहता ही रहता है. इट्स ओके, लाइक यू डोंट नीड टू ट्रीट इट. सो इसके ऊपर थोड़ा मैं जानना चाहूंगा प्लीज.
एक्चुअली आई टेल यू वन थिंग कि इफ आई टॉक अबाउट ब्लड प्रेशर, तो वो चीज़ तो है नहीं कि ब्लड प्रेशर ऊपर ही रहता है, वो चीज़ तो है नहीं, उसको ट्रीट करना ही पड़ता है.
ओके.
मतलब वी हैव टू ट्रीट दोज पेशेंट्स हु हैव हाई ब्लड प्रेशर. बट कॉमन सिम्टम्स जो आते हैं, जैसे आप बुखार बोल रहे हो, ये एक बहुत ही डिफिकल्ट सिचुएशन होता है, कि हर किसी को सीरियसली लेना है या नहीं लेना है. तो हम
राइट.
इसमें क्या करते हैं, क्लिनिकल जजमेंट लेते हैं, पेशेंट्स की सीवियरिटी देखते हैं, पेशेंट्स के सिम्टम्स देखते हैं, फिर उसके ऊपर से हम डिसाइड करते हैं कि इसको फर्दर इन्वेस्टिगेट करना है या नहीं करना है. बिकॉज
ओके.
इन्वेस्टिगेशन इज अ लॉन्ग टर्म प्रोसीजर. मतलब मैं करता जाऊँ तो महीने तक इन्वेस्टिगेशन कर सकता हूँ एक डिसीज के ऊपर. बिकॉज
राइट.
मेडिसिन एक ऐसा फील्ड है जहाँ पे डायग्नोसिस कैन बी एनीथिंग. मतलब मैं एक चीज़ बोलूँगा वो भी डायग्नोसिस है, सामने वाला एक चीज़ बोलेगा वो भी डायग्नोसिस है. So there is nothing permanent on this. तो it's an endless list of investigation that we can do. तो ऐसे सिचुएशन में हम क्या करते हैं कि वी डिसाइड कि कौन से पेशेंट को क्या इन्वेस्टिगेशन करना चाहिए, कौन सा पेशेंट क्रिटिकल है. कुछ फिजिकल साइंस एंड सिम्टम्स होते हैं, कुछ पेशेंट का हिस्ट्री बेस होता है, जिसके बेसिस पे हम डिसाइड करते हैं कि किसको फर्दर इन्वेस्टिगेट करना है. बट कई बार ये भी होता है कि सिम्टम्स इनिशियली छोटे रहते हैं, हम इग्नोर कर देते हैं, फिर देन इवेंचुअली वी सी द फर्दर सिम्टम्स एंड देन वी आइडेंटिफाई ऐसा हुआ था. आई कैन जस्ट गिव यू एन एग्जांपल. वी सॉ वन पेशेंट हु वाज आई थिंक 31-32 ईयर ओल्ड फीमेल. शी केम टू अस विथ हेडेक. पहले 15 दिन तक हेडेक हेडेक करके आई थी. इट वाज माइल्ड हेडेक. सो हमने उसको बोला कि ठीक है, हेडेक इज नोन, he was going through exam stress and all that was going on. So in these kind of situations we see that headache is there. So हमने उसको symptomatic supportive care दिया and we thought it's not required to investigate right now because there is no other complaints. And then we continued this for 10 weeks, 10 days to 15 days. And after 15 days she came to us with directly seizures. She was
Oh,
having
okay.
epileptic seizures and then she was unconscious when she came. And
Hmm.
then we did an MRI and then we found out that there was a venous clot. We in the age of, अब कैसा है, cerebral venous infarct at the age of 32, it is not commonly seen. अब मैं
Hmm.
हर एक हेडेक के पेशेंट का MRI नहीं कर सकता,
Right.
बिकॉज ऐसे सिचुएशन थोड़े डिफिकल्ट हो जाते हैं. बट देन इन सच सिचुएशंस यू हैव नो सॉल्यूशन. लाइक जैसे ये पेशेंट आया, देन वी फाउंड आउट दैट इट वाज सीबीटी, वी ट्रीटेड हर, शी वेंट बैक होम, एवरीथिंग वेंट फाइन. बट डू यू डू MRI फॉर ईच एंड एवरी पेशेंट? That's not an answer. So such difficult situations are also there, but normally what we do is we decide based on the clinical features and symptoms.
Okay. Now we want to know more about the case study, like rather your achievement of this man who you have treated, who had this intestinal tuberculosis. So how it started, and then how have you treated him? And
Right.
then
So
diagnosis
now,
is of course a very big part in this.
right. So it's actually the diagnosis part. बाकी तो कुछ है नहीं, एक बार diagnose
बाकी
हो
तो
गए
कुछ.
everything easy है, हाँ.
Right.
So actually
Right.
कैसा है? So what happened was this patient is from Mumbai and the patient was actually going and seeing local doctors there. इंडिया में एक बड़ा ये भी कॉन्सेप्ट है कि अपन पहले अपने फैमिली डॉक्टर्स के पास जाते हैं.
Right.
एंड मोस्टली जो क्या होता है ना, आई डोंट नो राइट एंड रॉन्ग, बट टू बी वेरी फ्रैंक, this is something which is wrong in India, because I have not practiced in India for a long time. So now when I'm seeing this in India, I feel really sorry for it. We have our local family doctors who are mostly Ayurvedic doctors, homeopathic doctors, जिनका knowledge level is restricted. They have limitation of certain knowledge. एंड देन
Okay.
व्हाट हैपेंस, वी वेस्ट अ लॉट ऑफ टाइम देयर, कि फीवर आ रहा है, फीवर जा रहा है, आ रहा है, जा रहा है. सो 8 to 10 days आई थिंक ही वेस्टेड देयर कि फीवर आ रहा है, फीवर आ रहा है. एंड नॉर्मली फीवर आ रहा है तो फिर पैरासिटामोल, एंटीबायोटिक्स, ये वो चलता रहता है. दिस कंटिन्यूड फॉर 8 to 10 days. देन ही स्टार्टेड लूजिंग वेट. देन ही वाज रेफर्ड टू अ स्पेशलिस्ट इन मुंबई and he went to a specialist there. There he spent another 1 month. Fever is coming, going. He's having pain abdomen, sometimes sweating. Just continued for another 1 month. He was losing weight. He was actually 94 kg. And then by the time he reached to me, he was almost 72 kg. So he had lost 20 kg in
Okay.
almost 2 months. So that drastic weight loss, loss of appetite था, high grade of fever, 103, 104 fever, not able to diagnose. Because normally क्या होता है जब fever आता है, so we all as our speciality we know that fever है तो one thing is tuberculosis, look for tuberculosis. So we normally screen for the lungs if we have TB. So वो जो basic part है वो सब किया हुआ था, that lungs were screened, there was no TB. A skin test for TB was done, that was negative. Basic blood test for malaria, typhoid, ये सब किया हुआ था, all that was negative. So there was no diagnosis found. Finally, after 1 month, he came to Pune, and then he was referred to us from another specialty hospital. And coincidentally, this patient saw that news article what we had written about ocular tuberculosis, and
Okay.
seeing that article, he was referred that, and then he came to me that I have
Mm-hmm.
seen this article of yours where rare diseases have been found out that this is there. So we admitted him. For me also, the first 3 days it was blank कि हो क्या रहा है, because सब कुछ वो पहले
Mm-hmm.
से करके आया था, कुछ नहीं दिख रहा था. So then we
Mm-hmm.
thought let's see for genetic diseases. Normally genetic diseases females में common होती है. We don't see them in
Okay.
males. The incidence
Okay.
of male to female ratio is 1:3. Like for
Okay.
every three females, if they have genetic diseases, one male can have genetic disease. So that's the ratio. So it is, if
Mm-hmm.
I take female to male, it is 3:1 ratio.
Mm-hmm.
So then we thought quite possible कि इसको हो सकता है autoimmune disease. So we tested autoimmune disease, it came negative. And then one day he told me that मुझे कभी कभी बीच बीच में pain abdomen होता है. So that's the only complaint, vague complaint he gave me. And I don't know whether he gave it previously or not. और क्या होता है ना, when you are giving drugs, when you're giving antibiotics, pain abdomen, nausea, this is a common symptom which every
Mm-hmm.
patient has because of medications also. So then somehow on seeing the patient on physical examination, I had a high end suspicion that ये हो सकता है कि intestinal TB हो. So then we
Okay.
called for a colonoscopy. We posted him for colonoscopy, and we could see a large number of ulcers there. Normally क्या होता है tuberculosis of colon और intestinal tuberculosis में large intestine, small intestine दो भाग होते हैं
Right.
अपने digestive system में. So
Right.
जब tuberculosis ulcers होते हैं, they are mainly seen in colon. They are mainly seen in the large intestine.
Okay.
स्मॉल इंटेस्टाइन में नहीं होते हैं. तो
Mm-hmm.
इसके जो अल्सर्स थे वो लार्ज इंटेस्टाइन से लेकर स्मॉल इंटेस्टाइन में ऊपर तक थे. So we could see
Mm-hmm.
multiple ulcers in the large intestine and the small intestine. So when we saw
Mm-hmm.
this, the first thing that we thought was not TB. We were like, अरे चलो ये तो TB है ही नहीं. The first thing that we
इसमें
thought.
इसमें
Yeah.
एक क्विकली एक मेरा क्वेश्चन है, जो अल्सर्स थे विच यू फाउंड इन द लार्ज इंटेस्टाइन विच वर स्प्रेड टिल स्मॉल इंटेस्टाइन एज वेल, क्या ये अल्सर्स, एक तो टीबी तो डेफिनेटली निकला, ठीक है, उसको ट्रीटमेंट भी हुआ, क्या ये अल्सर्स कैंसरस भी हो सकते थे?
नहीं
क्योंकि
एक्चुअली.
कैंसर, क्योंकि
Yeah.
कोलन कैंसर के अंदर भी जनरली इट इज सीन कि आपको अल्सर्स आपके लार्ज इंटेस्टाइन के अंदर होते हैं.
या सो उसमें क्या है ना, कोलॉन कैंसर की मॉर्फोलॉजी बहुत अलग होती है. लाइक द
अच्छा.
अल्सर
ओके.
स्ट्रक्चर्स वो पिकुलरिटी अलग होती है. लेकिन
ओके.
ये जो अल्सर्स कोलॉन में और लास्ट स्मॉल इंटेस्टाइन में थे, वो देखने के बाद स्मॉल इंटेस्टाइन में जब हमने अल्सर्स देखा, वी वर लाइक दिस इज नॉट टीबी, दिस इज डेफिनेटली नॉट अ टीबी, बिकॉज वी
ओके.
डोंट सी स्मॉल इंटेस्टाइन अल्सर्स इन टीबी. सो वी वर लाइक अच्छा चलो टीबी तो है ही नहीं. दिस वाज द फर्स्ट इंप्रेशन वी हैड. एंड देन वी टुक द बायोप्सीज एंड वी वर थिंकिंग कि ये क्रॉन्स है. देयर इज समथिंग कॉल्ड एज इन्फ्लेमेटरी बॉवल डिसीज, जिसका एक टाइप
ओके.
होता है क्रॉन्स डिसीज. और क्रॉन्स डिसीज में अल्सर स्मॉल इंटेस्टाइन लार्ज इंटेस्टाइन दोनों में आते हैं. क्रॉन्स डिसीज में भी पेन एब्डोमेन होता है, क्रॉन्स डिसीज में भी फीवर हो सकता है. सो हमको लगा ये क्रॉन्स डिसीज है. सो वी वर ओके सेटिस्फाइड कि चलो क्रॉन्स डिसीज है, नथिंग टू वरी. And then this is what we thought. We did the biopsies, we sent the samples for analysis, but somehow those ulcers were looking like वो थोड़ा confusion था कि Crohn's में ulcer small intestine में होते हैं, but the kind of presentation he had, it doesn't fit completely into Crohn's. It goes in favor of tuberculosis also. So इसीलिए हमने TB का टेस्ट भी भेज दिया साथ में कि चलो चेक करके देखते हैं. So this is what we thought. It was just a high index of suspicion, and we sent it for TB analysis also. And when we saw the biopsy report, we were shocked to see that it turned out to be TB. And that's how we diagnosed it at TB. But somehow we still had in back of mind, let's see, एक महीना वेट करके देखते हैं, शायद एक क्रॉन्स होगा. Let's start treating with TB and then see how he goes. And the moment we started him medicines for tuberculosis, within 3-4 days the fever disappeared. Then we
Okay.
were like, okay, fine. So TB has this is what we thought. But this happens. This is very common situation in medical fraternity. ये बहुत commonly होता है हम लोगों के साथ, because any disease can come in any presentation, so that's how we started treating him for TB. And after 2 months we repeated the colonoscopy and all the ulcers disappeared, completely normal colon after that. So we treated it for TB and left it, and then we understood that it's not Crohn's.
Amazing.
Yeah,
Kyuki I was studying about this case study, and then I found that that is written that there are 2% of patients globally who are found with this rare disease of
correct,
intestinal
correct.
tuberculosis.
Yes.
तो थोड़ा सा अगर इसका कुछ डेटा अगर आपके पास है, थोड़ा इंटरेस्टिंग अगर कुछ, तो प्लीज डू शेयर विद अस.
Yeah, so now normally what happens is intestinal TB भी जब दिखता है ना, it is secondary TB. मतलब पहले लंग्स
ओके.
में टीबी आता है और वहां से वो स्प्रेड है के कोलन में जाता है.
ओके.
सो हमारे लिए क्या होता है, इट
बट
इज
इनके
इजी.
केस के अंदर ऐसा नहीं था.
नहीं था, लंग्स का टीबी था ही नहीं, इट वाज नॉर्मल. द प्राइमरी ट्यूबरकुलोसिस बैसिलाई फॉर हिम सीन वेयर इन द कोलन, उसको लंग्स में कुछ था
ओके.
ही नहीं. सो नॉर्मल प्रेजेंटेशन ऐसा होता है. सो क्या होता है ना, हम जब लंग्स में टीबी देखते हैं और उसके साथ उनको देखते हैं कि सिम्टम्स आर देयर फॉर पेन एब्डोमेन, सिम्टम्स आर देयर फॉर लूज मोशंस, वी लेबल इट एज डिसेमिनेटेड टीबी, like extended from pulmonary TB to the abdomen, and we treat them. Then
ओके.
it becomes very easy. But this scenario is completely different, where you don't see anything in the lungs. So primary tuberculosis is not there, or the lung pathology is not there. What we saw was directly intestinal tuberculosis. Iska incidence बहुत rare है. There are a lot of cases being reported. Even if you see the 2% number, it's a big number. 2% is a big
राइट.
number when you see across the globe. So in that scenario, then it becomes like very rare entity, but still it can be something which can be easily found out. It's just that you need that high index suspicion, जिसकी वजह से फिर then you can pick up those cases.
ओके. अमेजिंग. आई वुड से कंग्रेचुलेशंस टू यू सर. पहली चीज. दूसरी चीज ये कि बहुत सारे रेयर डिजीजेस हैं, जैसा कि आपने खुद ही बताया, दैट दे गो अनट्रीटेड. उनका डायग्नोसिस ही नहीं हो पाता एट टाइम,
नहीं
कि
होती.
वो हुआ ही क्या है और क्यों हुआ है, उसका रीजन तक नहीं पता चल पाता. So, yeah, I mean, if there is any other information, of course, if you want to share about this particular disease or maybe the rare diseases, please do share. Because that is how we would like to end our episode.
Right. So I just want to tell one thing which I was being taught when I was doing my post graduation, that rare things happen rarely, common things happen commonly, but rare things cannot be ignored. This is what my professor used to always tell me. The
Okay.
first thing when you see a patient is look for common diseases first. So this is what we always do. But most important is when you don't see a common disease, don't give up. Try to dig for the rare diseases, because rare things are still diseases. So this is one thing which we were always taught when we were studying post graduation in medicine. So because of that, I always tell people also that all my patients also, do not ignore any symptom. uh, like जिस इस पेशेंट में था पेन एब्डोमेन, उसको था, I wish he had told that pain abdomen on day one. So then it would have been very easy for us to pick up, you know.
Right.
So कोई सिम्टम पेशेंट्स के लिए छोटा हो सकता है, बट वो हमारे लिए बहुत बड़ी चीज हो सकती है. It could just give us a clue that there could be something else inside. So
Right.
do not neglect any symptoms. That is one thing which I want to tell you. Any symptom can be very important for us to click a diagnosis. That is one thing which is very important. Secondly, whenever you have a disease which is pulling on for more than 5 to 7 days, make sure that you see a specialist for that. Do not
Okay.
waste your time running around the general practitioners, because you are wasting time, and wasting time can lead to a lot of complications. So
Mm-hmm.
initial few days, छोटी मोटी चीजें हैं, yes, you can go ahead and get treated from your local family doctors. But if any disease is persisting for more than 7 days, just visit a specialist and see what it is. That is one important thing what I want to tell. I would like to tell one more case which we saw. I don't want to name the patient.
Mm-hmm.
A guy from Pune itself was a karate teacher by profession,
Okay.
and he was referred to me for dengue. The
Mm-hmm.
dengue test was positive. He had fever, so we saw fever for 5 days. And while treating him, I see one day I was just talking to him, because I have that curiosity to talk to my patients and find out about their profession. And so I was just telling him, कि, how is your profession? What do you do? How do you work? And then he told me, बाकी तो डॉक्टर सब ठीक है, बट मुझे ऐसा है ना, कई बार मैं बाइक पे बैठता हूँ ना, तो मुझे पेन होता है. सो एंड देन ही सेड कि मुझे ये ना 4-5 साल से हो रहा है. सो जब बैठता हूँ बाइक पे तो दर्द होता है, फिर जैसे ही बाइक से उतर जाता हूँ ठीक हो जाता है. And this is what he said, and he just left it. And then somehow we were thinking that is this fever coming because of that, or is it actually dengue
Mhm.
what we're treating with? And that's the whole reason why I thought let's just get tested. So we just did some physical maneuvers. Now there is something called a psoas muscle in our body, जो अपने hip joints को connect करता है, जो hip
Okay.
joints को strength देता है, right?
Okay.
And what happens is when you are sitting, it is the psoas muscle that is acting. So I thought let me just check the physical maneuvers to check if the psoas muscle is working fine. And when we just did that flexion movement for him, he had a terrible pain there.
Okay.
नॉर्मली क्या होता है ना, जब हम लेटते हैं और ऐसा ऐसा फ्लेक्स मूवमेंट नॉर्मली किया नहीं जाता अपना, सो वो कभी रियलाइजेशन में नहीं आता कि ये पेन था, मुझे ये पेन हो रहा है, बिकॉज दैट इज नॉट अ नॉर्मल थिंग टू डू एवरी डे फॉर अस. So then we saw that something is wrong, and that's why we did an MRI scan for him, for the pelvic muscles and psoas muscle, and we found a large tumor present there sitting inside, on the psoas muscle. And
Okay.
then we found out that dengue is just a small thing what we're dealing with. There is something bigger which we have to deal with. And
Mhm.
we went for a colonoscopy. We did a colonoscopy guided biopsy for him, and the biopsy showed that there was nothing as such, but the mass was there. So we did a PET CT scan for him to find out if there is hidden malignancy inside, because it was a huge mass sitting on the psoas muscle.
Okay.
एंड पेट सिटी में भी बहुत सारे वैरायटीज होते हैं. सो नॉर्मल
Okay.
पेट सिटी जो करते हैं उसमें वो टेस्ट नेगेटिव आया. इट सेड दैट इट इज इन्फ्लेमेटरी रेस्पॉन्स एंड देयर इज नो मैलिग्नेंसी. But the fever was there, and he was having a little bit of weight loss. So we went for a surgery. We did an exploratory laparotomy, and we drained out all the content from there. क्योंकि कई बार क्या होता है जब कोलोनोस्कोपी करके बायोप्सी निकालते हैं, ये भी
Mhm.
बहुत ज़रूरी है कि हम बायोप्सी उस जगह से निकालें जहाँ पे मांस है. और
Okay.
मांस के सराउंडिंग एरिया में पस होता है, कलेक्शन होता है, फ्लूइड कलेक्शन होता है. और अगर
Mhm.
मेरा नीडल जाके वो फ्लूइड में हिट करके वापस आता है, सो आई विल
Mhm.
नॉट सी एनीथिंग इन द रिपोर्ट. तो वो बायोप्सी रिपोर्ट नॉर्मल आएगा, बिकॉज मैंने
Okay.
मास से सैंपल ही नहीं लिया. और इट इज़ वेरी डिफिकल्ट. इट इज़ ऑल इन मिलीमीटर्स एंड सीन बाय माइक्रो कैमराज वेयर वी आर हेडिंग एंड वेयर आर वी टेकिंग दैट बायोप्सी. सो
Okay.
वो बायोप्सी रिपोर्ट नेगेटिव आया, पेट सीटी नेगेटिव आया. सो देन when we did an exploratory laparotomy, prepared slides, and then we saw it shows that presence of malignant cells were there, but there was no cancer as such defined by the biopsy. Only
Okay.
cancerous cells were there, but कौन सा कैंसर था ये नहीं पता था. So then we sent that patient to Tata Mumbai, and Tata Memorial Hospital Mumbai, Tata Cancer Institute. They saw the patient. We discussed with them that this is something which we are not finding, and then they saw the patient. They said, "Let's see. We'll repeat a scan and see." They repeated the scan, but they also could not diagnose anything. Then the patient came back to us, and we were again in a question mark. पेशेंट बेचारा आया डेंगू से था, अब झूल कुछ और चीज में डायरेक्शन में जा रहा था. Then you
Right.
understand that patients also get frustrated when this is happening, that
Right.
you come for something small and then suddenly something big comes out, and it's just 32 34, I guess. So then there is another kind of PET scan which we normally don't do it for routine cases. So we did that,
Okay.
and then we found out that there was something called as peritonitis carcinota. So there is something called as the malignancy of peritoneum. Peritoneum is a bag which covers the abdomen. उसका
Okay.
malignant cells हमें pelvis में मिला. So then that's how we could be able to find out that it is something like this. And this is the rarest disease. I have seen it in my life for the first time. मैंने लाइफ में
Okay.
पहले कभी ये नहीं देखा था. So then we sent the patient back to Tata Memorial Mumbai, and then we told them that this is what is there, and then they gave us a protocol that this is how it's supposed to be treated, and then we continued treating that patient. Now the patient is on treatment for that, but small symptoms can be big, and we
Where
cannot
is
say
he
anything.
right now? Like, you know,
He's
how
in
is
India
he?
right
Where
now.
is he?
He's good. He's good.
Okay.
He's doing well. We did a repeat PET CT, and the PET CT is negative for cancer now. This is an old case now. It's been 6 months now. So patient is doing well.
Okay.
Patient is back to work. Things are okay, and luckily
Amazing.
things are very well now. बट ऐसा हो जाता है कई बार कि सिम्टम अपन इग्नोर करते हैं, बट क्या पता वो चीज़ बड़ा निकल जाए. So do not
Right.
neglect any symptom. Do not take your health casually. Just make sure that anything going wrong, just discuss everything with your doctor. Just be frank and open about your health and your symptoms. Something small can for you can be big for us, and
Right.
that's the only thing which I want to tell you all.
ग्रेट, थैंक यू सो वेरी मच डॉक्टर. आपने बहुत सारी स्टोरीज भी शेयर करी और बहुत सारे केसेस में ऐसा डिफिकल्ट डायग्नोसिस मैं बोलूँगा कि आप फाइंड आउट कर पाए, जो कि मतलब ईज़ी नहीं है.
Right.
So आपने बहुत अच्छा चीज बोली towards the end, which you said that कि आपका कोई भी even the smallest of the symptom if you have, do not ignore it. Maybe it is a small for you, but it may be big for the doctor. So आप जरूर डॉक्टर को कंसल्ट करिए एंड मतलब अगर भगवान ने चाहा, अगर आपका डॉक्टर सही है, डायग्नोसिस हो जाता है प्रॉपरली, so yes, you can make it. So on this note, thank you so very much. It was lovely having you and बहुत सारी information हमें मिली and हमारे viewers को मिली. Thank you so much.
Thank you so much, dear. Good talking to you.